Thank you everyone who worked so hard to organize and coordinate this year's quantitative imaging workshop. I am going to review our work at Leahy Hospital and Medical Center to help facilitate today's discussion on how low-dose CT scans can be used to identify early lung disease and why this should be considered a clinical imperative. At Leahy, we're working to develop a COPD center of excellence. We believe effective patient population-based COPD management falls into three groups, and that each need a specific and focused care plan. Our inpatient COPD initiative serves as a direct bridge between the inpatient and outpatient teams during the acute post-discharge period. A team consisting of a pulmonary trained physician and 2 advanced practitioners consult on every COPD admission in our hospital system. The primary goal of the consult is to address modifiable risk factors associated with hospitalization and to ensure COPD management is optimized. The key aspect of our team's design is the provider who sees the patient in the hospital performs the follow-up visits. This provides additional resources for the primary care and outpatient pulmonary providers. In addition, we are working to build a chronic care cohort. These are the patients who are at higher risk for admission, and the goal is to follow these patients every month and add as an additional resource for the primary care providers and to help facilitate the outpatient care plan that was developed during the previous hospitalization, and to help address acute exacerbations. Finally, the focus of today's talk is a lung health clinic, where the primary objective is to intervene before disease develops. So all patients who qualify for lung cancer screening at our institution are eligible for our clinic. For patients still contemplating screening, the visit will encompass shared decision-making. The visits can be virtual or in person. During these visits, if the patient has had a CT scan, we'll review the results, and then we'll perform risk stratification with the objective of identifying, does the patient qualify and should they have pulmonary function testing for COPD screening? What's their immunization status? Will they benefit from pneumococcal or influenza vaccination? And then finally, smoking cessation. We have shown in our institution that smoking cessation embedded in a lung cancer screening program can reduce active smoking rates. Finally, there'll be a subset of patients who we identify who would benefit from referral to our COPD team of specialists who focus primarily on emphysema and COPD. And within that, there will be a subset of our patients who may benefit from evaluation for surgical and endoscopic lung volume reduction surgery. In addition, we're currently being supported by a grant through Genentech to study interstitial lung abnormalities in our patient population. And we hope to one day incorporate a standardized scoring system for interstitial lung abnormalities at Leahy. Today, I'm going to discuss briefly some of the data that we recently submitted for publication from our cohort, and an additional validation cohort from Mount Auburn Hospital in Cambridge. So our 2 cohorts for Leahy and Mount Auburn, we started our cohort in January of 2012, and patients were screened through September 30th, 2017. And the Mount Auburn cohort started screening in 2015, and once again followed through 2017. All patients had the ability to follow up all the way through September 30th, 2019. As you can see, the patients are very similar between the 2 cohorts in terms of gender, race, smoking status, and emphysema. I would like to point out one of the limitations of our cohort, and that it's predominantly white. And we are actively working with Bay State Medical Center and Boston Medical Center to add them to our research projects as validation cohorts with a higher minority representation. As you can see at Leahy, in a standardized fashion, we scored emphysema as present or absent, and then also scored it as mild, moderate, and marked by our radiologist. Whereas Mount Auburn, it was standard protocol to identify emphysema as present or absent, but they did not qualitatively score it. Okay, so some of the data I'm going to show, I'm going to try to go through this briefly for the sake of time. We looked at the risk for hospital admission in our cohort, and we found that approximately 26, almost 27% of our patients were admitted at least once to the hospital during the study period. And at Mount Auburn, it was approximately 21%. And patients with emphysema had a higher risk for hospital admission And when adjusted for covariates, only in the Leahy cohort was this still found to be significant, with approximately a 34 and 52% increased risk for hospitalization in patients with moderate and severe emphysema. I do want to stress that within our cohort, the data represents only patients admitted within our network. We estimate that approximately 30% of our admissions occur outside of network. So if anything, we're underestimating the rates of hospitalization in both patient populations. Here's a graphic representation of hospital admission and the presence of emphysema for Leahy cohort and for Mount Auburn cohort. And now I'm going to talk a little bit about COPD. COPD was found to be associated, emphysema and risk for COPD admission was found to be significant in both the Leahy and a replication cohort at Mount Auburn. Approximately 74% increased risk for admission to the hospital for COPD, and at Mount Auburn, it was a 2.5 times hazard ratio for hospital admission. And once again, as the degree of emphysema increased, the risk for hospitalization increased. Here's a graphic representation of risk for COPD admission with the presence of emphysema as yes, no, and then by severity for the Leahy cohort, and then yes or no for the Mount Auburn cohort. We also looked at the risk for hospital admission for pneumonia, and we found that within the Leahy cohort, approximately 3.6% of our patients were admitted at least once for pneumonia through the study period, and at Mount Auburn it was approximately 4%. Only severe emphysema was associated with almost a 2.7-fold increased risk for hospital admission, and that was within the Leahy cohort. That was not found to be true in a smaller replication cohort. Here's the graphic representation that shows that as emphysema progresses, the risk for hospital admission for pneumonia increases. I just want to talk briefly about our quantitative imaging work. We utilize Philips ISP 9.0 platform and their COPD module to measure global and lower emphysema scores. The scores are divided by percent LAA minus 950 for the following ranges: less than 1%, 1 to 5, 5 to 10, 10 to 20, and greater than 20%. Our data suggests that a threshold of approximately 5% at a global Hounsfield units of minus 950 is where we identify where the risk for mortality increases. The results were also similar for our hospitalization data and for our COPD admission data, but for the sake of time, I'm not going to review that data today. Here's the Kaplan-Meier survival estimate for emphysema. As you can see, 5% is really where the threshold starts to have an increased risk. So then the question is, why does this matter and what can we do? So we wanted to look at our cohort to see if there are modifiable risk factors that we could improve at our institutions. So we looked at patients with in-network primary care physicians. This would ensure that we had the data to review and that it was accurate. At Leahy, this was approximately 70% of our cohort, and at Mount Auburn, the study was limited to all in-network patients, so represent 100% of their patients. So within both cohorts, approximately 57% and 55% of the patients had emphysema on their baseline CT scans. Of the patients with emphysema, almost 57 and 55% at Leahy and Mount Auburn respectively were actively smoking at the time of their baseline exam. As I mentioned, we were part of a multi-center study that showed aggressive smoking cessation programs embedded in lung cancer screening can reduce active smoking rates. We also looked at what percent of our patients had pulmonary function testing. And not surprising, this has been reported in other literature, almost 70% of our cohort and almost 80% of the Mount Auburn cohort did not have pulmonary function testing within 5 years of their baseline exam in patients with documented emphysema on their CT scans. And we also looked at pneumococcal vaccination. So pneumococcal 23 vaccination is recommended in patients with lung disease, specifically emphysema. And we found that almost 40% of our cohort and over 50% of the Mount Auburn cohort had not yet received pneumococcal 23 vaccination and would benefit from its administration. Finally, I want to review quickly a little bit of our lobar emphysema data. To qualify for endoscopic lung volume reduction, patients need at least one lobe with greater than 25% lung destruction defined as an LAA minus 950 at 25%. Of the 130 patients, roughly 3% of our cohort, who had at least one lobe with greater than 25% lung destruction, only 20% had full pulmonary function testing within 2 years of their baseline scan, and we were able to assess for eligibility. Of those with full PFTs, roughly 35% qualify. So using the Phillips algorithm, we estimate that roughly 1% of the patients at our institution who are screened for lung cancer will qualify and should be considered for referral for endoscopic lung volume reduction evaluation. So in summary, we currently score and report emphysema and coronary calcification on all our CTLS exams. As I mentioned, we are actively working to develop a similar reporting for interstitial lung abnormalities. Our goal is to eventually develop a standardized quantitative report that will help risk stratify patients for emphysema, coronary artery disease, and interstitial lung abnormalities. So what I've shown is our lung health clinic will encompass all disease. These low-dose CT scans can be used for more than just identification of lung cancer screening, as this group knows very well. So we've shown some data that we can identify COPD early, and there are things we can do to intervene to hopefully prevent the progression of disease. We can modify patients' risk for pneumonia. Hopefully we'll have some more data in the near future about interstitial lung abnormalities, and can we identify patients at risk for progression? We can identify patients at increased risk for MI, and is there things we can do to modify and risk stratify? I have data that I did not present today that suggests we can identify patients at increased risk for cardiovascular events and optimize their blood pressure and lipid profiles. Pulmonary hypertension, we have data that shows that an elevated PA/A is associated with COPD, which has been reported previously, and also associated with CHF emissions. And finally, there are other areas that we can look at for early lung disease, such as bronchiectasis, and things that are outside of lung disease, including metabolic syndrome and patients' bone health and their risk for fractures. So once again, I really want to thank you for the opportunity to present today, and I really look forward to the discussion. Thank you.